Hey everyone, this is Mrs. Lewis, and I'm going to give you a review of the heart, and we're going to talk about just some of the concepts that are important that you've probably already received in level 2, but it's really important for you to understand these things, so I'm going to do a review. So first thing, we're going to talk about the heart, and the heart is a 4-chambered hollow muscular organ. So if you look, you will see your 1, 2, 3, 4 chambers. And you've got the septum here in the middle. The heart is basically, like I said, a muscle. So you've got some muscle here. And the reason why I like this picture is because it shows you everything here, so that you can see it, and the fact that the lung is very important in this process. The lungs are very important in this process. You have 3 layers. The heart has 3 layers: the myocardium, epicardium, and the endocardium. And if you look, you can see the endocardium is here. It's in pink, light pink. Then you've got your myocardium, which is there, basically, in green. And then your epicardium, which is right here, drawn in blue on the outside. So those are your 3 layers. The heart is covered by a fibrous sac called the pericardium, and the sac has 2 layers. The inside is like visceral layer of the pericardium, which is like the epicardium, and the outer layer is called the parietal layer. A small amount of pericardial fluid is about 10 to 15 milliliters that lubricates the space between those layers. It prevents friction and keeps the heart kind of bobbing around in there. So if you ever have a problem with swelling or extra fluid or not enough fluid, or the heart's enlarged, then that's when you're going to hear the pericardial rub. And we're going to talk more about that later. Now, the heart is regulated, of course. We're talking about the structures and functions of the cardiovascular system. And the heart is regulated by our autonomic nervous system, baroreceptors, chemoreceptors, and of course your autonomic nervous system consists of your parasympathetic and your sympathetic. Sympathetic is your fight or flight. We've talked about that already. When you get scared, your heart rate increases, so that you can have fight or flight. Your parasympathetic is your rest and digest. That is when your body decides, okay, we need to calm down, we need to get through this, and you will notice that the baroreceptors and the chemoreceptors are pretty important as well as far as regulating the cardiovascular system. So your baroreceptors in the aortic arch and the carotid sinus, they are sensitive to stretch and pressure. So think when your patient has volume overload, those baroreceptors send information to the vasomotor center in the brain, and this results in a temporary inhibition of the sympathetic nervous system. So the baroreceptors are stimulated, like from increased volume or pressure, and this results in inhibition of the sympathetic nervous system. Inhibition just means, it tells it to stop, So you get an inhibition of the sympathetic nervous system and an enhancement of the parasympathetic, which would be decreased heart rate and peripheral vasodilation. And this is something the body does. It is part of the body compensating. Then you've got your chemoreceptors. They're also in the carotid bodies in the aortic arch. They're capable of causing changes in the respiratory rate, and it can help when you are a little acidic, it when you're acidic, your blood pressure goes down. So those chemoreceptors in the medulla are triggered, and they stimulate the vasomotor center to increase the blood pressure. So an example would be you have someone that is in acidosis, and they have increased O2 pressure, hypoxia, and those chemoreceptors are triggered, and they trigger the vasomotor center to increase the blood pressure. To compensate, right? That's what the body does. This is all part of compensation. So that is just some regulation of the cardiovascular system. And then I want to go over this blood flow through the heart. Some of you may say, I know this. I don't need to go through this. You can fast forward through this or skip it along. But this is something you really, really need to know, especially if you're going to understand preload and afterload and some of the other concepts that we're talking about this semester. So make sure you understand this well. So first, we want to talk about the blood. So where does the blood come from? Well, the blood, as you can see, it comes there from the body, from the upper body and from the lower body, into the superior vena cava and the inferior vena cava. So you've got blood that comes in to the heart, goes into the right atrium. The blood then goes through the tricuspid valve into the right ventricle, and then out to the lungs. And you can see the blood, I colored it blue because it's not oxygenated yet, right? It has to go to the lungs and get oxygenated. Now when it's in the lungs, if you remember, it's oxygenated, carbon dioxide and oxygen exchange there in the lungs in those alveoli sacs, and then it comes back from the lungs, it's red, it's oxygenated, and it goes into your left atrium, then your left ventricle, and then up through the aorta valve and through the aorta into systemic circulation. So that is the blood flow of the heart. And if you look, the left side is a stronger pump. This is a higher pressure pump, and you can tell this. You can see this muscle is bigger. Naturally, you've got a larger artery. Your aorta is larger, and so those things, those factors, are part of getting the blood out to the rest of the body, to systemic circulation. So you can imagine if this is damaged, or if you've got down in your body, if you've got constriction, high blood pressure, things that are constricting your vessels, your systemic circulation, it's going to be harder for this to pump it out, okay? It's going to have to work harder to pump it out. Now let's just talk about quickly the valves. You know these, you should know these. Your tricuspid, so the blood, comes from the right atrium to the tricuspid, and then through the pulmonic, and then the right ventricle expels blood through that pulmonic valve here into the pulmonary trunk. The pulmonary trunk divides into the right and left pulmonary artery, each which carries blood to the lungs, and blood flows to the pulmonary arteries to the lungs, where it's oxygen and carbon dioxide are exchanged like we already talked about. And then you've got your blood that flows back from the lungs to your left atrium, then your mitral valve, and then up through your aortic valve. and then out through the aorta and the rest of the body. And your last one is your aortic, and then your pulmonic and your aortic are semilunar. So these valves help prevent blood from regurgitating right back into the system. So if there's a damage to the valves, that's when we get our murmurs. So you will hear the murmurs if there's a problem with the valve. So another part of the mechanical system of the heart is your systole and your diastole. Systole is contraction of the myocardium. Your diastole is the relaxation of the myocardium. Your stroke volume, that's the amount of blood ejected with each heartbeat. So 60 to 150 milliliters each heartbeat. So think about the heart beating. So each time it ejects 60 to 150 milliliters per beat. That's your stroke volume. You may see it written as SV. And then your cardiac output is the amount of blood pumped by each ventricle in 1 minute. And that's usually 4 to 8 liters per minute. That's your cardiac output. So that's a lot of blood, right? So it's amount of blood pumped by each ventricle in 1 minute. That's your cardiac output. You may see it written as CO, different places. And then, of course, you need to know this. Your cardiac output equals your stroke volume times your heart rate. And you will need to know that. We'll talk more about that when we talk about the hemodynamics. But that is that's important to know. And then we've got other factors that affect your cardiac output. So we've got lots of factors that affect cardiac output, that affect this mechanical and portion, the mechanical workings of your heart. So let's talk about preload. What is preload exactly? It's just the volume of blood in the ventricles at the end of diastole. So if you know where diastole is, when you're talking about the heart, remember lub-dub, lub-dub. Volume of blood in the ventricles at the end of diastole is the stretching of the myocardial fibers. You sometimes will hear people refer to Starling's law when they're talking about preload because it involves the stretching. And preload can be increased to a number of causes, such as MI, aortic stenosis, hypervolemia, because you've got that extra fluid and that extra volume, right? And then contractility is just the contraction of the heart, right? So think about the heart contracting, squeezing. This can be increased by epinephrine, norepinephrine. Definitely think about your sympathetic nervous system when your heart's beating faster. It's going to contract faster. And then your afterload is just your peripheral resistance against which the left ventricle must pump. So we're back to our left ventricle. Remember I said it's the higher pressure. It's a stronger ventricle. It has to pump blood out through the systemic circulation. So your afterload is the peripheral. Remember, peripheral is your systemic circulation, the resistance against which the left ventricle must pump. So I want you to think about enlargement of the cardiac muscle or ventricular hypertrophy. So those things could affect your afterload. If there's something wrong with that pump, that muscle, that left ventricle, then you're going to have a problem with afterload. And then, of course, your electrical system. We're going to have a whole lecture on this. So I'm just going to give you a brief review of this. You've got your SA node, which is the basically the pacemaker of the heart. It kickstarts your heart, right? Then your AV node controls the heart rate by connecting your right atrium and your right ventricle through internodal pathways, through electrical impulse, right? Then after that, it moves along to the bundle of His, this electrical impulse, and then down into your Purkinje fibers. That helps with ventricular conduction, right? So that your heart will squeeze. So these cardiac muscle cells, we got to go back to the beginning, right? When we talk about action potential, this is the action potential is your impulse, the depolarization, the impulse at the cellular level. So you want to think that these cardiac muscle cells, they have this compensatory mechanism that can help them to with the electrical part of the heart for conduction. Now put this here because I wanted you to think about what happens when you have a buildup of fats. Soft deposits of fat. So I drew those yellow marks. You know, they say that that fat starts depositing at an early age, like in your teens. And we don't know it because we don't test teenagers for cardiovascular disease. And then, you know, later in life when you're in your 40s and you start having problems, that's when they find it. So we're trying to teach prevention for all ages and just be more aware of cardiac health. Now, cardiac artery disease, you know, your coronary, your heart, has its own arteries. It has its own blood supply. If you've never thought about that, then think about it now. So the myocardium has its own blood supply called the coronary circulation. Now we are not going to require you to know all of these vessels, the left main, the right main, where's the blood, where's the clot, where's the heart attack happening on the EKG. Now if you specialize and you go into ICU and you work, you will know. You'll be able to look at the EKG and, you know, decide where in the heart this heart attack happened. But as of right now, we're just talking about the fact that these vessels, these arteries and veins, can get occluded from soft deposits of fat. So, what happens? The fat is deposited in the vessels, and over time, these soft deposits of fat harden with age, and it becomes atherosclerosis. These fatty deposits are called atheromas. And I don't know if I'm saying that right. Hopefully I am. So you may hear this referred to as coronary heart disease, cardiovascular heart disease, ischemic heart disease, arteriosclerotic heart disease. So all of these, or CAD, coronary artery disease, all of these are considered heart disease. And basically, when you have a buildup of this, of these fatty deposits, then you will definitely start seeing some signs and symptoms of shortness of breath, chest pain, sometimes high blood pressure, different things like that. So I just marked cardiovascular disease, or CAD, is when you're starting to get the fatty deposits and the plaque that builds up. Now, you've got these non-modifiable risk factors such as age, gender, ethnicity, family history, genetics. Some of these things you can't help. You're going to be, this person, your patient's going to be more prone because of those reasons, more prone to cardiovascular disease. But then you've got your modifiable, lipid levels, hypertension, tobacco, drugs, activity level, obesity, diabetes, and psychological stress. So any of these things are modifiable, and you think, is diabetes really modifiable? Well, not always. Sometimes it is hereditary, sometimes, but being compliant with the diabetes is a part of being modifiable. Just like hypertension. If you're compliant with your meds, it's a modifiable risk because it's proven that if the patient's compliant, they have a lower risk. Lipid levels, if you change what you're eating, your diet, and maybe even go on some medications for lipids, then sometimes you can modify your risk factors. Lose weight, obesity, psychological stressors. So, managing your stress in a healthy way. So all of these things can be modifiable risk for heart disease. And then I am going to stop it right here. We're at 20 minutes, and we will continue on through a little bit more about heart disease and, chest pain, and go into acute coronary syndrome. So if you have any questions, please see me, call me, email me, seek me out, and ask me, and I will see you soon.